Good afternoon, my dear students. Topic of today our lecture will be chronic pancreatitis. On this picture you can see anatomy of the pancreas. It have weight from 75 till 125 grams, size from 10 till 20 centimeters. It lies in the retroperitoneum just anterior to the first lumbar vertebra. Anatomically divide on four portions: the head, neck, body, and the tail. Pancreatic duct. It's the main duct of the pancreas. It begins in the tail of the pancreas and runs along its posterior surface. Receive numerous tuberculars at right angle along its length. It joins the bile duct to form hepatopancreatic ampulla. Accessory pancreatic duct of Santorini. It begins in the lower part of the head, opens into the duodenum at mirror duodenal papilla. It is from 6 till 8 centimeters from the pillarus. On this picture you can see arterial supply of the pancreas. You see all arteries what supplying the artery blood to the pancreas. Nerve supply of the pancreas are from the vagus nerve. That's why vagotomy have a big role in functioning of the pancreas. Chronic pancreatitis. It is a benign inflammatory process and fibrosing disorder characterized by the irreversible morphological changes, progressive and permanent loss of the endocrine and endocrine function. Clinically, the disease is characterized by the recurrent episodes of severe and uncontrollable upper abdominal pain and by a loss of exocrine function, diarrhea and steatorrhea, and endocrine function, diabetes mellitus. Incidence of chronic pancreatitis from 3 till 10 on lakh population, more common in men, middle age is more than 40 years old, 2/3 are alcoholic reasons. Etiology. There are toxic, idiopathic, genetic, autoimmune, recurrent acute pancreatitis, and obstructive. Let's talking about them. First, toxic. Alcohol consumption from 16 till 90%, tobacco, hyperkalemia, and uremia. It is the reasons. Idiopathic. Up to 20% of the patients with chronic pancreatitis have no known risk factors. Based on the bimodal age of onset of the clinical symptoms, two distinct entities. Early onset idiopathic chronic pancreatitis happens in the first 2 decades of their life. Abdominal pain, pseudominant clinical feature, pancreatic calcification, and exocrine and endocrine pancreatitis insufficiency are very rare at the time of the diagnosis. Late onset of idiopathic chronic pancreatitis happened in the 5th decade of their life, usually painless course, associated with significant exocrine and endocrine pancreatic insufficiency and pancreatic calcification. Topically, pancreatitis is one of the most common forms of the chronic pancreatitis in certain areas of southwest India. Topical pancreatitis is generally a disease of young and early adulthood, with a mean age of onset of 24 years. The disease clinically manifests as abdominal pain, severe malnutrition, and exocrine or endocrine insufficiency. There are three genetic factors that have the main role in formation of the chronic pancreatitis. It is cystic fibrosis transmembrane conductance regular factor. It is serine protease type 1 factor and serine peptidase inhibitor causal type 1 factor. Autoimmune factors. Rare but distinct form of chronic pancreatitis characterized by the specific histopathologic and immunologic features. Autoimmune disease, viral infection. Hallmarks are periductal infiltration by lymphocytes and plasma cells, granulocytes epithelial lesion and destruction of the duct epithelium, venulitis, minimal abdominal pain, diffuse enlargement of the pancreas without calcification and pseudocysts, most commonly involved the head of the pancreas and the distal bile duct. Obstructive. Scar of the pancreatic duct, tumors of ampulla of water, and head of the pancreas. Trauma. Main pancreatic duct obstructing may lead to the stagnation and stone formation by pancreatic juice, lead to recurrent pancreatitis, periductal fibrosis, chronic pancreatitis. Now you can see all levels of the pathogenesis in formation of the chronic pancreatitis. Clinical features: abdominal pain, exocrine insufficiency, steatorrhea, diarrhea, fat-soluble vitamin deficiency, such as bleeding, osteopenia, and osteoporosis. Endocrine insufficiency leads to diabetes mellitus, jaundice or cholangitis, rarely upper GI bleeding. Abdominal pain is the most common and most debilitating. Initially, pain manifests after consumption of the food. Later on, it becomes continuous and affects quality of life. Epigastrium often with radiation to the back, boring, deep, and penetrating. Relieved by the lying forward by assuming the knee chest position on one side. Loses appetite, weight lost, addition analgetics. Proposed two mechanisms of pain. First, increased pressure and ischemia. Second, injury and alteration in peripheral and central nociceptive nerves. Increased pressure and ischemia. Obstruction in duct lead to increased pressure, similar to compartment syndrome where increased pressure leads to ischemia with cause pain. Alteration in peripheral and central nociceptive nerves demonstrated increase in the diameter and number of intrapancreatic nerves, foci, and inflammatory cells associated with nerves and ganglia, and damage to the perineural sheath. The destruction of the perineural sheath may allow inflammatory mediators to gain access to the neural elements. The accumulation of inflammatory mediators and nerve injury can sensitize the nerves, making it hyper-responsive. Chronic pain due to chronic peripheral nerves injury of inflammation lead to changes in nociceptive processing that involved both the spinal cord and CNS. Chronic pain can produce a centrally sensitizing pain state in which elimination of the original source of pain does not relieve pain. Exocrine insufficiency, steatorrhea and azoturia, protein maldigestion do not usually occur until pancreatitis enzyme secretion is reduced to less than 10% of the maximum output. Advanced chronic pancreatitis, maldigestion of fat, protein, and carbohydrates occur present with diarrhea and weight loss. Median time to develop of exocrine insufficiency was 13 years in patients with alcoholic chronic pancreatitis. Exocrine insufficiency, deficiency of fat-soluble vitamins, significant vitamin D deficiency and osteopenia or even osteoporosis occur, bleeding manifestations. Endocrine insufficiency. Chronic pancreatitis also affects islet cells population. 40 to 80% of the patient will have clinical manifestation of diabetes mellitus. Islet cells appear to be relatively resistant to destruction in chronic pancreatitis. Diabetes mellitus typically manifests later. Extrapancreatic complications. Jaundice may be seen in the presence of coexistent alcoholic liver disease uh, or bile duct compression within the head of the pancreas and duodenal obstruction. A palpable spleen may also rarely be found in patients with thrombosis of the splenic vein as a consequence of chronic pancreatitis or in patients with the portal hypertension due to coexistent chronic liver disease. Diagnosis based on the functional test and imaging of the pancreas. Functional test. Fecal elastase, the first level of the preferred non-invasive study to diagnose the pancreatic exocrine insufficiency. Lipase and amylase are of minimal diagnostic value, but in our country we check in the alpha amylase of the serum and diastase of the urine. It gives us information about the activity of the necrotic process inside of the pancreas. For imaging can be used CT scan, MRI, and ultrasound examination. On this picture you can see a lot of the calcificates inside of the pancreas. Here is enlarged Wirsungov ducts. We can see a lot of fibrosis mass inside of the pancreas and calcifications inside of the pancreas. On this MRI picture we can see the stone what obturate the Wirsungov duct. ERCP was historically considered the gold standard for the diagnosis of the chronic pancreatitis. Indications include patients for whom CT and MRCP are contraindicated or failed to corroborate the diagnosis. Therapeutic modality: the pancreatic duct compilations amenable to endoscopic therapy such as stricture, stones, pseudocysts, and biliary stenosis. Endoscopic ultrasound was emerged during the past 25 years as the most accurate technique to diagnose in the early stages of the chronic pancreatitis. On this picture you can see how looks this investigation. Answer: management for abdominal pain and pancreatic insufficiency, steatorrhea. Pain management: most debilitating symptom of the chronic pancreatitis, as well as the one most often requiring medical care. Identify associated condition for which specific therapy exists: pseudocysts, duodenal obstruction, carcinoma. Some patients' pain may be managed with acetaminophen. NSAIDs should be avoided. Pain management clinic should start with non-narcotic analgesics. Mostly they fail. It is useful to begin with lower potency opioid agent like tramadol. Gradually increase the dosage while focusing the patient on the goal of control of pain to a acceptable level rather than complete relief of the patient. The risk of opioid addictions is estimated to be 10 to 30%. Pain relief is the first priority. Adjuncts: tricycle antidepressants modulating central pain perception, potentiate narcotics, gabapentoids, gabapentin, and pregabalin. Of course, if the patient who drank the alcohol stopping to do this, he will feel relief of the pain. Using of the antioxidants and pancreatic enzymes can reduce the pain too. Endoscopic management. Goal of endoscopic therapy is to improve drainage of the pancreatic duct by relieving ductal obstruction. Limited to a subgroup of patients with amenable pancreatic ductal anatomy. Stent placement and sphincterotomy. Stenosis of the sphincter has produced obstructive chronic pancreatitis. Complications are clogging of stent, production, recurrent pain, attack of the acute pancreatitis, or pancreatic sepsis. Stent migration, which may require surgical extraction, and ductal perforation. Extracorporeal shock wave lithotripsy. Its removal of the large or impacted stones requires lithotripsy. Surgical treatment of the chronic pancreatitis is based on two main conceptions. First, resection of the tissue, non-dilated pancreatic ducts, pancreatic head enlargement, or if a pancreatic carcinoma is suspected. And second, drain and preservation of tissue to prevent future loss of the pancreatic function. Indications: intractable pain, symptomatic local complications, unsuccessful endoscopic management, suspicion of malignancy. Drainage or decompression procedure. Duval described using distal pancreatotomy and splenotomy with an end-to-end pancreatitis between the cut end of the body of tail and the pancreas and the raw XY limb for jejunum to decompress the pancreatic duct. Pusto and Gillespie, they modified Duval's procedure. A longitudinal opening along the main pancreatic duct through the tail and body of the pancreas and then invaginating the distal gland into the raw XY limb of jejunum. Longitudinal pancreatitis. Partington and Rochelle describe the side-to-side longitudinal pancreatitis that is currently referred to as the modified Puesto procedure. Remains as a standard approach to pancreatic ductal decompression, best applied to patients with parenchymal disease and pancreatic ductal dilatation, artificially improving the pancreatic head, neck, body, and tail of the gland. Minimal diameter of the pancreatic duct should be more than 7 mm, should not be any mass in the pancreatic tissue, omitted splenectomy, distal pancreatotomy. 75–80% of patients with diffusely dilated main pancreatic duct and no dominant inflammatory mass have achieved durable pain relief over 5–10 years of follow-up. Morbidity is low. Because no pancreatic parenchyma is removed, endocrine and exocrine function are generally preserved. On this slide you can see how looks the resection procedure for pancreas. Hybrid procedure or Frey procedure. Frey's introduced a procedure that combines duodenal sparing resection of the pancreatic head without formal division of the neck of the pancreas, combined with longitudinal pancreatitis of the dorsal duct. On this picture you can see how this hybrid procedure looks. Next type of treatment is the total pancreectomy with islet autotransplantation. It performing in case of small duct disease, diffuse parenchymal inflammation, hereditary syndrome, failure of the prior pancreatic operations, nerve blocks and neurolysis. The celiac plexus transmits visceral efferent impulse from the pancreas. The greater, lesser, and least splanchnic nerve travel from the celiac plexus and then pass through the diaphragm to reach the spinal cord. Celiac plexus block usually using a combination of glucocorticoids and long-acting local anesthetic like bupivacaine. Celiac plexus neurolysis using an injection of absolute alcohol can be administered by CT and endoscopic ultrasound guide technique. They are used in pancreatic carcinoma. Splenectomy block central perception of the nociceptive input. Involves section the great splanchnic nerve on one or both sides. 15-75% will get pain relief. The multiple spinal levels that received input from the splanchnic nerves and the variation of the numbers of the splanchnic roots make complete neurotomy difficult. On this slide you can see summary of today our lecture. You can conspect it and use during the preparing to exams. Thank you for your attention, and now I propose to you to look a few videos about today's topic.
Thank you very much. So again, the topic of my talk today is autoimmune pancreatitis. My disclaimer, I don't have much to discuss for this that's of any conflict to me. I thought about adding another disclaimer to this, which is this is a very uncommon problem, and I don't think anyone has scads of experience with this, but I'll talk about what experience I have and kind of review the literature. As a background, this is a relatively new diagnosis. This was first clinically described back in 1965, but wasn't recognized as an autoimmune disease until 1995, and the well-known association with IgG4 was only recently described in 2001. It's been estimated to be with an incidence of up to 1 in 100,000 patients. I think this is probably an overestimate. And in the literature, it's reported to be a finding in 2% of surgical resections for suspected adenocarcinoma. It's important to keep in mind that this is often part of a spectrum of IgG4-related diseases that could include autoimmune pancreatitis, IgG4-associated cholangiopathy or cholangitis, salivary gland involvement, tubulointerstitial nephritis, can't pronounce that one, mediastinal fibrosis, retroperitoneal fibrosis, and occasionally IBD. There are two types. There's two different terminology systems for this. Type 1 and type 2 is used to define the clinical syndrome. The terms lymphoplasmacytic sclerosing pancreatitis and idiopathic duct-centric pancreatitis refer to the pathologic features, which generally overlap. Type 1 autoimmune pancreatitis is generally found in elderly males. Type 2 tends to be slightly younger patients with an equal male and female prevalence. Type 1 is associated with elevated serum levels of IgG4, whereas type 2 is not. Likewise, type 1 is associated with positive staining, where again, IgG4 staining, whereas type 2 is not. The pathologic features of type 1 consist of lymphocytes and plasma cells infiltrating the tissue, a characteristic form of fibrosis called storiform fibrosis, and obliterative phlebitis. Type 2 is associated with similar features, plus the finding of these characteristic features called gels or granulocytic epithelial lesions. Type 1 is frequently associated with other organ involvement, whereas type 2 is very rarely associated with involvement of other organs. Type 2 is, however, associated with IBD and perhaps up to 30%, and relapse is much more frequent in type 1 than type 2. So how do we diagnose it? Well, first it's important to think about when we should be thinking about the diagnosis, and the typical clinical presentation can be one of obstructive jaundice, vague abdominal pain, usually not severe, the finding of a pancreatic mass incidentally on imaging, and occasionally patients with elevated pancreatic enzymes, but very rarely in the setting of clinically acute pancreatitis. Less common presentations can be the presence of idiopathic relapsing acute pancreatitis. Again, I said it's uncommon but does occur, and in the setting of new onset diabetes. It's important to keep in mind that the presence of cachexia, anorexia, and narcotic requiring pain is highly suggestive of malignancy and very atypical for autoimmune pancreatitis. There have been multiple diagnostic guidelines that have been proposed to aid in the diagnosis of autoimmune pancreatitis. Most commonly used nowadays are the high-sort criteria and the ICDC, or International Consensus Diagnostic Criteria. The high-sort has advantages of being very easy to remember and easy to use, and I'm going to focus on these today. However, the ICDC are more sensitive, more accurate, and probably should be used for research purposes. There are other diagnostic guidelines available. That by the JPS is not frequently used in the US because it mandates the use of ERCP, which is really frowned upon in most American centers. So focusing first on the high-sort criteria, it's easy to remember because the name stands for what it is. H stands for histology, I for imaging, S serology, O other organ involvement, and RT response to therapy. The presence of one or more of these characteristic features is felt to suggest the presence of autoimmune pancreatitis. So histology, we'll talk first about type 1 and then move on to type 2. There are several characteristic histologic features. The most frequent finding is the presence of a dense lymphoplasmacytic infiltrate. It's found particularly periductal and without the presence of granulocytes or PMNs infiltrating in the tissue. In addition to that, per the ICDC guidelines, you should have at least 2 of the following findings. The presence of obliterative phlebitis, which is shown at the bottom here. That's a vein that's completely occluded. The presence of storiform fibrosis, and this is a very characteristic finding, and we tend to try to convince our pathologists to call this when we see fibrosis on a biopsy, but it really has to be storiform, and the word storiform means spiral. It's like a spiral staircase. The way I can remember it is by thinking of this picture, which really is what it looks like. This is a starry night, starry, I can remember it that way. But anyway, this kind of swirling of fibrosis is characteristic of type 1 autoimmune pancreatitis. And then the finding of abundant, more than 10 per high power field, IgG4 positive cells. In the ICDC guidelines, if you have only one of those 3 findings, it's felt to be level 2 evidence rather than level 1 evidence, and I'll get to that in a little bit. Type 2 is similar features, however, in the setting of absent IgG4 staining and the presence of these gels, granulocytic epithelial lesions, which you see at the arrow there. These are little clusters of neutrophils infiltrating in through the tissue. Like many things, there's things that break these rules, and I should point out that the finding of gels has also been reported in the setting of type 1 autoimmune pancreatitis, but in general, we think of that as being a feature of type 2. I'll point out here, and I'll point out later, that the ICDC guidelines mandate histology to obtain a diagnosis of type 2 autoimmune pancreatitis. And this is again because of what I pointed out on an earlier slide, that these patients do not have elevated serology, they don't have elevated IgG4 levels, and they tend not to have other organ involvement. So how do we get the tissue? How do we get histology to document this diagnosis? Well, something that's done in a lot of centers, we tend not to do it, is to do an ampullary biopsy. And if we review the pooled literature, the sensitivity is about 64% or so for ampullary biopsy. The issue is that it's not specific. And so this study from the American Journal of Clinical Pathology in 2013 showed that 24% of patients who had ampullary biopsies with other diagnoses also had greater than 10 IgG4 positive cells in the ampullary biopsy. This included 2 of the 6 patients with adenocarcinoma enrolled in the study and 7 of 18 patients with celiac disease. So what else can we do? Well, we can get core biopsy, and you can get core biopsy percutaneously or core biopsy by endoscopic ultrasound. We tend to pursue endoscopic ultrasound. Unfortunately, the largest series that's been done on this technique has been unpublished, but they have reported their data several times, so I'll summarize this. This was by Mike Levy and the group at the Mayo Clinic. The reason they haven't published it is because it used this needle that you see over on the right, which is a true cut needle used to obtain core biopsies of the pancreas, and that needle is now obsolete. But what they found is that 35 of 48 patients, or 73%, they were able to obtain adequate histologic material to obtain a definitive diagnosis, and complications were relatively rare, some mild pain and one case of self-limited bleeding. Now, there are new needles that are available that have kind of replaced that TrueCut type needle, but there's very limited published data on these to date. And so we're really waiting to see whether these newer needles can obtain adequate material, but I think most of us who do this presume that it will, just based on the gross appearance of the material that we get in the room. So moving on from H to I, imaging, there's both parenchymal and ductal imaging that we look for with autoimmune pancreatitis. The typical or classical appearance on a CT scan would be the presence of diffuse enlargement with delayed enhancement. And here you can see this diffusely enlarged sausage-shaped pancreatic body and tail, and that's highly suggestive of autoimmune pancreatitis. Sometimes we get this rim-like hypodense halo around the pancreas. Sometimes you can get biliary duct wall enhancement, which you see here. Atypical features would include segmental enlargement or segmental delayed enhancement, which again needs to raise your index of suspicion for malignancy. And then I'll point out that abnormal imaging is present in about 85% of patients with autoimmune pancreatitis. So how do we tell whether something's malignant or benign? And this is really one of the crucial aspects of this talk. It's extremely important when you're thinking about the possibility of autoimmune pancreatitis to make sure that you have excluded the presence of malignancy and make sure that you've discussed this with your patient. The finding of a focal mass with pancreatic duct dilation strongly favors malignancy, and you should have a very, very high degree of clinical suspicion for malignancy in that setting. Factors that would favor autoimmune pancreatitis include the presence of that diffuse sausage-like enlargement that I showed earlier, the presence of that low attenuation halo, the presence of a non-dilated main pancreatic duct upstream from the area of abnormality. And then I will point out again that an enhancing bile duct wall is seen in about 50% of these patients, but we can also see this in other situations, such as ascending cholangitis and cholangiocarcinoma. Ductal imaging, typically obtained either by ERCP or MRCP. The pancreatic duct will be characterized by very long strictures, typically involving more than a third the length of the duct, and you can see that here. It's a very long stricture, again, without upstream dilation. Often you can have multiple strictures. In addition, at ERCP, the finding of side branches arising from the strictured segment is highly suggestive of AIP. The common bile duct will have strictures either in the distal duct mimicking pancreatic carcinoma or segmental strictures in the intrahepatic duct, which you can kind of see here. There's a stricture in the intrahepatic duct. Serology, typically we obtain IgG4 levels in this setting, and per guidelines, this should be more than twice upper limits of normal. And you can see here what happens to the sensitivity and specificity as we increase the required cutoff. The sensitivity drops to 53%, but the point of this is to try to maintain high specificity and eliminate misdiagnosis of malignancy as autoimmune pancreatitis. So we need to keep in mind that only about half of patients will meet IgG4 criteria and that elevation does not completely exclude malignancy. There are a variety of other serologic tests available, but these are all either nonspecific, reported in small studies, or generally not clinically available. Other organ involvement can involve a variety of things. This is an example up here of a diffusely thickened common bile duct wall, again in the setting of IAC. We can see patients with retroperitoneal fibrosis seen down here, lacrimal gland thickening enlargement, salivary gland enlargement, vasculitis. This is a case with IgG4-associated aortitis, tubulointerstitial nephritis, and in type 2, again, there's this association with IBD. Particularly ulcerative colitis. Here's just an example showing renal lesions in the setting of autoimmune pancreatitis. You can see on the left this patient with very dramatic areas of hypodensity in the right kidney prior to treatment and improvement in the imaging following treatment with prednisone. And moving on to response to therapy, this should only be performed after an aggressive attempt at excluding malignancy. But then once you've decided that you think there's a high likelihood of autoimmune pancreatitis, you can proceed with a treatment with high-dose prednisone, 40 milligrams a day or equivalent, and you look for a rapid response in imaging. That should be within 2 weeks. This is an example of a patient before and after prednisone. 2 weeks later, you can see dramatic reduction in the size of the pancreatic body and tail. Improvement in symptoms or CA 19-9 is not sufficient to establish the diagnosis. I'm going to very briefly discuss the ICDC guidelines because they're just too complex to use in immediate clinical practice. I think if you need to use these, you can review the publication and pull this up to look at it. But basically, it uses the same high sort criteria, but it's a much more complex and weighted criteria. There are 3 separate algorithms depending on the clinical scenario. It's flexible for both types 1 and type 2. Again, requires tissue for type 2. It's more sensitive and accurate than the high sort, but again, high sort does really pretty well. Sensitivity of 85%, accuracy of 88%, and it's probably the best approach for clinical trials. Now, I'll just show you what these look like, but again, this is way too busy to get into today. You can see that there are level 1 and level 2 evidence for different criteria, including the standard high sort criteria. There's different criteria for type 2, and then there's 3 separate algorithms that can be used depending on the clinical scenario to try to determine whether someone has autoimmune pancreatitis. So how do we treat it? These treatment recommendations will be based on a publication this past year that are international consensus for the treatment of autoimmune pancreatitis. And first, we need to decide who needs treatment and why. And important in that is to try to discuss what the natural history of untreated autoimmune pancreatitis is. And it's been reported that up to 70% of patients who are initially asymptomatic will develop adverse events within the first 2 years. This can include jaundice, presence of a pseudocyst, extrapancreatic biliary strictures, hydronephrosis due to retroperitoneal fibrosis, or tubulointerstitial nephritis. It's believed it can progress to atrophy, calcification, and duct dilation. There is some but unclear risk of the development of diabetes, but also 10 to 25% of these patients can improve spontaneously. So according to these international consensus guidelines, the indications for treatment would be symptomatic patients with pancreatic involvement manifested by jaundice, abdominal or back pain, or symptomatic other organ involvement, or asymptomatic patients with the presence of a persistent pancreatic mass on imaging, or persistent LFTs due to cholangiopathy. Induction of remission is with steroids unless there's a contraindication. And typical approach is shown here, but there are many variations on this. We typically use prednisone. It's recommended 0.6 to 1 milligram per kilogram per day. For most people, this ends up being 40 milligrams per day. It needs to be at least 20 milligrams a day, or it's ineffective. Continue this for 2 to 4 weeks. We usually do 4 weeks, and then assess for response. Then begin tapering by 5 milligrams per day every week. And using this approach, this has about a 98% likelihood of remission. If there's a contraindication to steroids, then the treatment is rituximab, not immunomodulatory agents, because just like with inflammatory bowel disease, they take too long to kick in. Relapse is fairly common with this technique. With type 1, it's been reported up to 31%, type 2 about 9%, and predictors of relapse include the presence of high baseline IgG4 levels, the setting of other organ involvement, the presence of a ductal stricture in the bile duct, and the presence of a persistent focal mass after the resolution of diffuse swelling. Maintenance therapy is controversial. It's more commonly used in Japan. We tend not to do it. But if you're going to think about maintenance, the time to think about using maintenance therapy prior to experiencing a relapse is in patients who have diffuse enlargement, a delayed radiologic remission, persistent elevation of IgG4 after therapy, more than or equal to 2 other organs involved, or the presence of proximal cholangiopathy with stricture. And then if used, maintenance is typically with prednisone 2.5 to 7.5 milligrams a day, rituximab, or immunomodulators. Treatment of relapse is a little bit more controversial. Some places use long-term steroids, some places use steroids and immunomodulators. There's a long list of immunomodulators that have been used in small studies. Some people use rituximab, and rarely surgery is used, primarily when there's concern about underlying malignancy that just cannot be completely alleviated. So in summary, the diagnosis of autoimmune pancreatitis is challenging. IgG4 levels are often not elevated. Tissue diagnosis is often not possible. Diagnosis requires clinical judgment and guidelines, and in my experience, often rests on response to therapy. Extreme vigilance is needed to exclude the presence of pancreatic carcinoma. This requires a careful discussion with the patient about the possibility of underlying malignancy for which treatment may be delayed. The initial treatment is steroids. Relapse is common, especially in type 1 with biliary involvement. Treatment of relapse is controversial. And finally, like many things, you're never going to find this diagnosis unless you know what you're looking for and you look for it, and beware of the wolf in sheep's clothing. Thank you.
Apart from cirrhosis of the liver and liver diseases, another big problem for patients who have alcoholism, chronic alcoholism, is chronic pancreatitis. And chronic pancreatitis can be either due to, as in usually in alcoholics, due to repeated insults of the pancreas, but it can also be seen in non-alcoholic patients due to autoimmune problems or other underlying disorders. So the anatomy is not really important for this particular lecture, but it is good to know that the pancreas kind of nestles in behind the stomach and in the C loop of the duodenum. So remember that the duodenum makes this kind of C after it comes off of the stomach. So into the second part of the duodenum comes the ampulla of Vater. The ampulla of Vater is just the confluence of the pancreatic duct and the common bile duct. So not much else to know there. Okay, here's our vignette. So a 54-year-old man presents to the ED complaining of severe subcostal upper abdominal pain, which radiates around his back. It started 3 hours ago, shortly after finishing a dinner of steak and French fries. He had a similar episode like this last week after eating, but was not seen because the pain went away before he could get to the hospital. He has not vomited and is not nauseous. He denies any changes in bowel movements or color, although he says he usually has loose bowel movements. Blood pressure 145/90, heart rate 100, respirations 22, temperature 98.8, saturation 93. He smokes tobacco and consumes alcohol regularly, about 6 beers during weekdays and 9 on weekends for the last 35 years. His last drink was this evening. He has no other complaints. He has no surgical history. His past medical history is significant for bipolar affective disorder type 2, which has been well controlled on lithium. He is also prescribed loperamide for daily use. Physical exam reveals a thin Caucasian male, upper abdominal tenderness, no distension, guarding, or peritoneal signs. His bowel sounds are diminished. Lungs are clear to auscultation. There's tachycardia, but a normal rhythm. Well, what are the labs you're going to get? For most cases of acute abdominal pain, I would say pretty much all of them, you're going to get a CBC, you're going to get a CMP, which is just a basic metabolic panel plus liver enzymes. You're going to get amylase. In this case, you're going to probably get lipase too because we're concerned with pancreatitis. You'll also want to get an EKG and plain films, either the chest, the abdomen, or both. Definitely in this case, the abdomen. And what do we find? So we got a CBC that's normal. The CMP reveals an elevated ALT and AST. AST is greater than ALT. Glucose of 323, which is really high. Amylase is elevated. Lipase is elevated. The EKG shows sinus tach. Chest x-ray is unremarkable, but the abdominal x-ray shows evidence of minor pancreatic calcifications at the level of the pancreatic head. And that's really the kicker there. Just with that word, that phrase, you should know that this is chronic pancreatitis. And you probably knew that because that's what this lecture's on. Don't be sly. All right, so how do we know before the labs that this is probably chronic pancreatitis versus acute pancreatitis? Well, we don't necessarily know for sure, but there are some things that may give us hints. Definitely not the pain. The pain is similar between chronic and acute pancreatitis. It might not be as severe with chronic pancreatitis, but that's difficult to gauge because different patients will report different pains as being severe or less severe. The pain came on after eating. That can happen with acute pancreatitis too, but with alcoholics, usually the pain does not come on after eating. Now with chronic pancreatitis, the pain is going to be worsened with eating. Why? Because that activates the pancreas. In most cases, patients with chronic pancreatitis, the pain will be connected to some kind of meal, especially a fatty meal, not carrot sticks. Another thing is that he says that he usually has loose bowel movements. Remember, what does your pancreas make? It makes lipase, and lipase is responsible for breaking down fat. If you don't break down fat, fat's going to be in your stool, and the fat is going to cause both gas and it's going to cause diarrhea. So you get steatorrhea and gas, and that's going to be the loose bowel movements. So the fact that he says he usually has loose bowel movements says something is going on GI-wise that he's not absorbing fats. Well, if he told you he had loose, oily bowel movements, I suppose. But chronic diarrhea, one of the things that you should think of is steatorrhea, i.e. chronic pancreatitis. Okay, the fact that he smokes tobacco, smoking tobacco is an independent risk factor for chronic pancreatitis. And then, of course, consuming alcohol regularly to the degree he does, 6 to 9 beers a day for the last 35 years. This guy, if you probably asked him, or if you look at his medical record, he's probably been in for acute pancreatitis at least once before. Also, that he's thin. So patients with acute pancreatitis can run the gamut from thin to obese. Patients with chronic pancreatitis have a tendency towards thin. They don't have to be, but they have a tendency towards being thin. Why? All back to this loose bowel movement issue. What are they not absorbing? They're not absorbing fat. And remember that fat is twice as many calories as a gram of fat is twice as many calories as a gram of carbohydrates or a gram of protein. So these patients are usually malnourished. Lab-wise, CMP reveals probably some alcoholic hepatitis. The AST is slightly greater than the ALT, so that points you towards an alcoholic hepatitis. The glucose is very high, and that is possibly pancreas in origin. So the glucose should never be 323, and that would be an immediate diagnosis of diabetes if you did see that. But what in the pancreas would cause you to get this high glucose? Well, having idiopathic diabetes mellitus, of course, but if you have chronic pancreatitis, you're not properly secreting insulin. And if you're not making insulin, then your glucose level is going to be higher. The amylase and lipase. This is not going to feature to the same degree as with acute pancreatitis. So remember, with acute pancreatitis, you can almost make the diagnosis based on the fact that amylase and lipase were more than 3 times the upper limit of normal. With chronic pancreatitis, that's not the case. So the amylase and lipase, usually when you have your acute pain episodes with the chronic pancreatitis, they may be elevated, but patients with chronic pancreatitis may also have normal amylase and lipase levels, or they may even have low amylase and lipase levels because the pancreas is getting burnt out. By the time it's chronic pancreatitis, its ability to secrete amylase and lipase is diminished. So even though you've got an event of pancreatitis, because this is chronic pancreatitis, the pancreas is burnt out and it's not able to secrete amylase and lipase like a healthy pancreas that becomes inflamed, acute pancreatitis. And then what's most important here, of course, is the evidence of minor pancreatic calcification at the level of the head. That's practically pathognomonic for chronic pancreatitis, and that's calcification as we see in a lot of different chronic inflammatory diseases. So the differential for acute epigastric pain can be lots of things, probably even more than this, but these are the things that I like to think about immediately in a patient with this kind of history. Maybe you can cross out Boerhaave syndrome because he doesn't have a history of vomiting, but these are some of the things I like to think of. You can probably cross out OBGYN issues since he's not a woman. If this were a young woman coming in with a similar history, I might add a beta HCG and a urinalysis to the initial workup. Okay, chronic pancreatitis is a chronic inflammation and destruction of the pancreatic mucosa, parenchyma, and ductal system. This is a completely different pathologic process from acute pancreatitis, but most of the time, patients who have chronic pancreatitis will have a history of acute pancreatitis because what's the big risk factor for chronic pancreatitis? Alcoholism. Same big risk factor for acute pancreatitis. In the US, it's almost always due to high alcohol consumption, but I should say with chronic pancreatitis, it's due to a long history of high alcohol consumption. So this isn't just your 1 week of binge drinking for Mardi Gras. This is a patient who has been an alcoholic for a long time. About 60%, and I would say that's a conservative estimate, of chronic pancreatitis can be directly related to the alcohol. About 30% are quote-unquote idiopathic, and about 10% are secondary to autoimmune or congenital diseases or malformations. Most prominent of those, cystic fibrosis, I would say also the autoimmune pancreatitis, which can be a feature of, it can present with primary biliary cirrhosis, present with primary sclerosing cholangitis, it can present with Sjogren's syndrome, or it can present entirely on its own. Men tend to be affected more than women overall. However, if it's autoimmune pancreatitis, women have a dominance over men as they do with most autoimmune diseases. Blacks tend to be affected more than whites, and I believe that is controlling for alcohol consumption. Black people have in the United States, have a per capita higher rate of alcohol consumption, but I believe that this statistic is correcting for that. All right, history. Very important to document the history and degree of the patient's alcohol habits, since that's behind most cases. Not just their habits, but how much they're consuming when they, you say, how much do you drink? Oh, 5 days a week. Well, how much are you drinking each night? A six-pack. Well, a six-pack of what? Is it strong beer or is it 3-2 beer? So you have to make sure when you're getting into the patient's alcohol history, details are really important. Because if a patient says that they had 2 drinks, but they were 2 little flimsy wine coolers, that's totally different than if they had 2 shots of 120 proof vodka. So important to have that documented very, very well in their history. As I mentioned, smokers are at a higher risk for pancreatitis, not higher than alcoholics, but smoking is an independent risk factor. So a drinker who smokes is even at higher risk. Also be alert for any past biliary problems as well. Symptoms. So why do patients usually come into the hospital? They come in because they don't feel good. They're in pain. And so that's the most common symptom on presentation, but it doesn't have to be the only position. Usually the pain is made better by certain positions, especially this, what I've seen, most of the patients that I've seen with chronic pancreatitis tend to prefer this specific position, and it's sort of laying on their side in the fetal position. And I'm not really sure why they do that, but I've even seen in the literature that this sort of sideways position is the most preferable for patients with pancreatitis. Patients with acute pancreatitis also tend to have that sort of doubled over position. Steatorrhea or gas may be a complaint. Usually, though, you have to elicit that. So it's important that you're getting a full GI history and symptomology. Check for physical signs of malnutrition. So you're looking for temporal wasting. You're looking for any kinds of signs of fat-soluble vitamin deficiency, A, D, E, and K. A laboratory examination, usually the glucose is going to be elevated. That's hypoinsulinemia from the chronic pancreatitis. Transaminases will also be elevated as well. That's not necessarily due to the chronic pancreatitis, but due to the fact that these patients tend to be alcoholics, and therefore they're also going to have some degree of alcoholic liver disease. They may have hypocalcemia. I'm not sure why, but my thought behind it is, well, they got to be putting their calcium. Their calcium has to come from somewhere where they're getting these calcifications. So maybe that's causing the hypocalcemia. Another thing, though, another cause of chronic pancreatitis is hypoparathyroidism. So I think I said that right. So patients who have high levels of parathyroid hormone, they can also develop chronic pancreatitis. Amylase and lipase are usually elevated in acute painful episodes, but they don't have to. So this is totally unlike acute pancreatitis, where if it was acute pancreatitis and we come back and see the amylase and lipase are normal, it's not acute pancreatitis. With chronic pancreatitis, the amylase and lipase do not have to be elevated, although they often are with the acute episodes. As far as radiology, you'll want to make sure that you're getting your abdominal x-ray in any patient you suspect chronic pancreatitis, because about 30% of them will develop or will demonstrate pancreatic calcification. And this is what that looks like. So when you're looking for the pancreas, usually go about 2 or 3 spinal levels up from the superior iliac crest, and that's where the pancreas is. When you see an abdominal x-ray in a normal patient, you shouldn't really be able to make out the pancreas. But if they have calcifications, you'll definitely see it. So here's calcifications here. These are widespread calcifications. You're not going to necessarily see all of these calcifications in your typical patient. So this is more like what a typical patient might look like, average patient presenting in with chronic pancreatitis. These are more advanced patients. So best way to sort of look for the pancreas, look about 2 or 3 levels up from the superior iliac crest. So 1, 2, 3, up. Here's the calcifications. And the pancreas can be in variable positions. It's one of the most anatomically variable organs, so it's not going to look the same in everybody. So here's where the pancreas is. Here's another one, again about 2 to 3 levels up from the iliac crest, right here. What do we do for chronic pancreatitis? We treat this similar to acute pancreatitis, but we don't have to as much worry about the complications. We're not as concerned about the development of sepsis and other things like that, hemorrhage. However, it can happen. It's not as in the front of our minds as with acute pancreatitis, which is much more of an emergency, much more lethal in the acute phase. So the treatment for them are going to be admission. We'll want to put them on pancreas rest, so NPO for 24 to 48 hours. Of course, we're going to be giving them IV fluids because they're not eating anything with glucose added onto that. Daily labs, analgesics for their pain. You can advance their diet as tolerated. We'll also want to give them pancreatic enzyme supplementation. There's various preparations of this. Pancrelipase is the one that I've mostly seen. There's another one called pancreazymin. And then a surgical consult. And the reason you want that surgical consult is before you discharge them, once their pain is gone, then you're going to get an ERCP or an MRCP on them to evaluate their pancreatic ducts. The reason you do that is because the surgeon is going to decide whether or not he or she wants to do a procedure. And the procedure can ameliorate future symptoms. The details of these procedures are way outside the scope for the USMLE and even for internal medicine boards. But what is important to know is that with a patient who's been newly diagnosed with chronic pancreatitis, you want to check their pancreatic ducts. And that is done by ERCP or MRCP, and then having a surgeon decide what the next step is. ERCP is the most accurate test for chronic pancreatitis. So I know step 2 often likes to throw at you which of the following is the most accurate test in the diagnosis of this patient. Well, ERCP is the most accurate test to diagnose chronic pancreatitis because it gives you a visualization of the ducts. So that is the most accurate test. However, ERCP is falling out of favor to MRCP recently because MRCP is getting better at visualization, and ERCP has that added unwanted complication of sorry, I'm having a mind problem here, of iatrogenic acute pancreatitis. Remember, you're injecting dye, and because you're injecting that contrast, you can cause acute pancreatitis, especially in somebody who's already got a compromised pancreas. So MRCP is sort of coming into trend, but ERCP is still the gold standard. If the abdominal x-ray is unremarkable when they come in, there are other ways that you can diagnose them with chronic pancreatitis. Remember, I said only 30% of patients with chronic pancreatitis will actually show those calcifications. You can also do an abdominal CT. This is much more sensitive than x-ray. This will diagnose about 70 to 80% of patients. You'll see calcifications on the CT as well. You can also do a fecal fat test, and that will come back positive because, remember, they're not secreting lipase. So they're not secreting lipase. The fat is staying in their stool. So here's pancreatic calcifications on CT. Much easier to see here than on the abdominal x-ray. So the complications of chronic pancreatitis include pancreatic pseudocyst, which would present as upper abdominal fullness or discomfort, not though the severe pain that we see with pancreatitis. Pancreatic adenocarcinoma, iatrogenic acute pancreatitis, if they're getting that ERCP at the end, which they should be, you can cause acute pancreatitis from that. Biliary or small bowel obstruction, that can be either due to a pseudocyst or it can be due to the chronically inflamed fibrotic pancreas. So you can get obstruction of the biliary tract, which of course is going to present a lot differently from obstruction of the small bowel. You can get splenic vein thrombosis, and that's again due to the chronic inflammation. The splenic vein is intimate with the pancreas, and so if you get thrombosis of the splenic vein, that's going to cause left-sided portal hypertension. So gastric varices and splenomegaly. Diabetes mellitus is kind of almost the rule with chronic pancreatitis because they're not going to be secreting as much insulin, so they'll have higher levels of glucose. And so for most of these patients, when you discharge them, you're going to be discharging them on some kind of pancreatic enzyme. And then, of course, inevitably there's progression or worsening of the disease if they don't stop smoking and stop consuming alcohol.